I want to welcome all of you to this educational symposium entitled The Oncology Nurse Takes on AML. And we're going to look at insight on recent therapeutic advances and how we can improve patient care. I'm Sarah Tinsley from Moffitt Cancer Center and the University of South Florida College of Nursing in Tampa, Florida. It's nice and warm and sunny there. It's nice here though too, and we don't have this view of mountains. I have colleagues with me tonight who are my good friends. Please welcome with me Natasha Johnson from Moffitt Cancer Center and Eileen Galinsky from the Dana-Farber Cancer Institute. We all take care of AML patients. Thank you very much. We are delighted to be here. I was talking to Natasha this morning and I welled up with tears. I was like, this is like my life. I've taken care of AML at Moffitt for the past 26 years, and I can honestly tell you, I thought this day would never come to when we would have new therapies that we can talk about. So I just want to relay to you, that's so exciting to me, and I hope you share in our enthusiasm tonight.
The following audio is based on a recent live symposium with Sarah Tinsley, Eileen Galinsky, and Natasha Johnson. This audio is part of a certified educational activity. To access the entire activity and complete the post-test, please go online to www.peerviewpress.com/QJG. A printable monograph, slides, practice aids, and other features are also available.
We're going to map for the oncology nurse your views on the future of AML. As you know, AML is the most common type of acute leukemia. It is a disease of our older adults with a median age at presentation of 68 years. So it's a person retirement age that this primarily affects, and older patients are generally undertreated. Selected older patients may benefit from intensive therapies, but as a group, they exhibit increased treatment-related morbidity and mortality. They have decreased complete response rates. They have increased relapse rates, and really what's very sad to many of us in the room, they have a decreased overall survival. So the majority die from their disease, and we want to change that. As these new therapies emerge, I would encourage each of you tonight to really consider what your role is in providing care to patients who are diagnosed with AML as these new therapies are FDA approved. As you know, the standard of therapy is currently chemotherapy driven, although patients from SEER data, we know that the majority of them have not been treated. 43% of over 4,000 patients receive chemotherapy, while 57% receive supportive care only. And you know what happens when you don't treat AML? They die of their disease, and they die more quickly for the most part. And that's what this is illustrating. The ones who had chemotherapy, 69% of them died within 1 year. And you can see the median overall survival was 7 months. And with supportive care only, 95% of them died within 1 year. So the chemotherapy did make a little bit of a difference for those who were treated. And if they weren't treated, they died usually within a couple of months, less than a couple of months. So this really illustrates for us that new therapies are needed, and we're right on the cusp of many of these being validated. And again, what is our role as oncology nurses as these novel agents emerge? Really, I'm going to try to help you understand the diversity of AML, what the emerging therapies are broadly, and then what does that mean for nurses? What do we do with this information? It's nice to know about it, but how does it directly relate to me and the care that I provide to my patients? Getting AML right starts with understanding the diagnostic workup and the prognostic issues. It's a disease of many presentations. We have favorable risk AML, such as our acute promyelocytic leukemia, where we can cure the majority of those patients, to secondary AML, where they will likely die of the disease. When patients ask you, what can you tell me about my disease, which is a common question that we see after a new patient consultation, many of them are terrified because they've Googled their diagnosis and Dr. Google has told them that they have a horrible prognosis. But really, we try to not take away all of their hope, but let them know that if we don't have our bone marrow biopsy and all of the information, we really can't address that question. Because if they had acute promyelocytic leukemia, you would be telling them a totally different story than if they had an AML that has a FLT3 mutation or a therapy-related AML, for example. So we begin, as with all of our patients, with a good history and physical examination. You want to assess for comorbidities, but really you also want to look at the patient's functional status. Are they able to walk? I got tickled with one nurse who says that she does functional assessments of patients that's really, they get them up, they walk them, they have them sit down, stand up, and make sure that they really are at the level that they say they are. And one guy said, yes, I walk. He walks back and forth to the bathroom. That was his definition of walking. So you really want to dig in and see what their normal activity is in a day when you're evaluating an older AML patient, or really any AML patient. And you want to look at the CBC with the differential, see what kind of cells are circulating out there in the peripheral blood. Are they mature cells or are there many blasts? You can see many times the disease out in the peripheral blood. And patients with AML are prone to bleeding disorders, disseminated intravascular coagulopathy. So you want to check coagulation parameters, your PT, PTT, and fibrinogen. Also, I would like to pause. I'm a quality of life researcher in AML. So of course, I would say you need to do a quality of life assessment because that's really important. It's not just survival that we need to look at, but we need to look at the quality of their survival. Are we just torturing them and they die and they live longer but die? Or do they have really an improvement in their quality of life? The cornerstone of a really accurate diagnosis is a bone marrow biopsy with aspiration. You always, always, always want to get the cytogenetic analysis from your bone marrow biopsies. If you don't have that information, you don't have adequate information to be able to tell the patient about what we recommend. And you also want to look at molecular analysis. We do what's called a next generation sequencing or a myeloid mutation panel. Each facility has their own panel that they use for looking at molecular analysis. If they're a candidate for hematopoietic stem cell transplant, you also want to do HLA typing before their counts are wiped out because you can't really do it then. You could do it after they were in remission if they get to remission, but then you've lost time. And if they have neurologic symptoms, you want to do a CT or an MRI of their brain. And once they don't have a lot of circulating blasts, you would want to perform a lumbar puncture. And the reason you would want to wait is because if you have a lot of circulating disease and you do a lumbar puncture, then you don't know if it's contaminant or it's really disease in the CNS. The patient asks you, is there anything about my AML that can help the oncology team pick the right therapy for me? I would interpret that as they're asking me if we can pick the winner for them. And you would counsel them and say, yes, there are many factors that influence the choice of treatment. Those things that we were talking about, cytogenetic analysis, there's patient factors and there's disease factors, and those all fit together for the team to come up with the appropriate therapy for a patient. And you could tell them when we stage AML, there's many different subtypes. And so we have to get the additional cytogenetic results and the mutation panel to be able to really inform them what their prognosis is and what we recommend for them. But we are going to discuss others, and that's where we're leading to. These are the traditional prognostic factors in AML. Age has long been included in our decision making. because we know the older the patients are, the less likely they are to respond to treatment. We look at comorbid conditions, antecedent hematologic disorder. For those of you that don't see AML patients every day, and for those that do, I'm sure you're aware that that means that they had a prior bone marrow problem. Either they had myelodysplastic syndrome before they had AML, or they may have had one of the other bone marrow disorders, such as a myelofibrosis or something along those lines, some other bone marrow disorder before they evolved to AML. We look at white blood cell count at presentation. The higher the white blood cell count is, that's usually more aggressive disease. And we look at cytogenetics. That's the karyotype from the bone marrow, where we look at dividing cells, and then they take the chromosomes and they line them up, and they see if there are any structural abnormalities, and then the molecular abnormalities. This is building on the traditional, these new prognostic factors in AML. We've known about cytogenetics for quite a while, but the molecular features of the disease are more of the new information that's constantly evolving. There are 3 primary risk categories that we think of for AML with cytogenetics. We have favorable risk that you can see as your core binding factor leukemias. That would be an inversion 16, translocation 1616, translocation 821. Those are your core binding factor leukemias. And then if you look at the bottom under mutation analysis, you can see that if a person had a favorable risk core binding factor, but in the presence of a KIT mutation, that would move that individual risk category from favorable risk to intermediate risk. And then we really use FLT3 and NPM1 to determine whether a person needs to go to transplant in first remission if they're healthy. If they have normal cytogenetics for a male, that would be 46XY, and for a female, it would be 46XX. And then if they have the FLT3 mutation, the FLT3 ITD, then that would move them to poor risk. And if they had a FLT3 negative normal cytogenetics with an NPM1, that would move them to favorable risk. So that's how that works. It's a little complicated, but if you see a lot of patients every day, and you do their staging in their prognostic category, then it comes more easily. And then more recently, we're really looking at post-treatment parameters such as MRD, as minimal residual disease, and we're looking at blast clearance. And what that helps to tell us is if at the end of their therapy, they are trying to determine whether or not to go on to transplant, or maybe they need to be put on some maintenance therapy to try to keep them in remission. We're going to do a couple of case studies per presentation tonight. I think that really helps for us to figure it out more. This is Emily. She has de novo FLT3 mutant AML. She's 60 years old. She worked at the post office for a long time, but she had to retire early due to a back injury. And as we educate patients, it's important to assess their ability to understand the information that we provide to them. What's their level of education? What's their level of understanding? So we learned that she has poor health literacy, and she doesn't really fully understand the effects of her AML symptoms, or her feeling so fatigued is related to the AML at all, or her degree of anemia. She's divorced, she has no children and no immediate family. And then she asks you to tell her, what does this FLT3 mutation mean for me and my disease? So you want to be honest with her and develop a plan. And we also want to help provide some support for her. Many times we try to involve our social workers. We also have supportive care medicine that can come alongside at Moffitt and help with identifying support systems for our patients. We explain the results of the FLT3 testing. For someone like Emily, I would probably just show her the result and say it's positive for the FLT3 mutation. but trying to really get her to understand it from a molecular basis, it's not going to happen. So you would tell her that for her disease, it means that she has more aggressive disease and that it's likely to relapse even with our current therapy. But we do have some options to think about, and they might be effective against your cancer. This is a closer look at the mutations and their prognostic relevance in AML. FLT3-ITD is at the top there at 30%. You can see it's associated with a worse prognosis. There's also the NPM1 mutation that we discussed previously, and that occurs in about 35% of AML patients, and this has a better prognosis overall. And then the next most frequent there is your IDH1 and IDH2 mutations. Eileen will be covering that later in the symposium tonight, and about 18 to 20% of patients will have an IDH1 or 2 mutation. We're going to move on to another case study. This is William. He's 75 years old, and he's lived a very active lifestyle, very good performance status, despite having MDS for the past 8 years. He does have a supportive wife of 40 years, and they fight every now and then like every husband and wife, but they have a good relationship that we can assess. And she's really there for him. They have 3 children, 7 grandchildren, and he's proud that he's been able to, beat MDS for the past 8 years. And the nurse, all of us, many of us, educate our patients and really help them understand their disease. But now he's transformed to a different disease that he doesn't really know as well as myelodysplastic syndrome. And he's depressed. And he said, I thought I was going to do okay, but now I have no idea what to expect. So once again, we would be honest with him and let him know this is what we would term secondary AML because they had myelodysplastic syndrome first. And we know that this is a hard to treat and challenging disease. But the good news is we have options, and you'll hear about the options later on in the presentation tonight, including a clinical trial. And you want to include his family in the discussion about the treatment options and what to anticipate. Many times the patient doesn't hear anything but blah, blah, blah because they're so stressed out. But those family members that are there in the visit help us by taking notes and really, reinforcing the information that was provided. And that really helps us because the families are an extension of our care, and they're right there. They're even closer, a lot closer to the patients than we are. And on your right, you'll see there's some support groups that you can refer him to. Our social workers are wonderful at Moffitt, so we would get them involved. So this is my study. William asks about quality of life. So how do you answer? You want to watch out for the age bias. The main reason I did a quality of life study comparing intensive versus non-intensive therapy in older AML patients is because I was a floor nurse. I took care of AML patients that were older, and I saw a lot of suffering, and I saw a lot of pain. And I was concerned that we were causing more harm than good. But my age bias was turned around when I did my study, and I found by doing the FACT leukemia before and 1 month after therapy in patients that were 60 years of age and older, that they had a significant improvement in their quality of life score at 1 month. That totally blew me away. I started crying. I'm like, you gotta be kidding. I must have done the statistical analysis incorrectly. So then I had a statistician look at it. Yes, no, this is right. This is what you got. And I'm like, wow, that makes me sleep better at night. Then the other thing for the non-intensive treatment, those were patients who got outpatient-based regimens. This is your hypomethylating agents and patients in clinical trials on oral therapies. They had stable quality of life at 1 month, so we weren't hurting them either. And then I looked at predictors of quality of life. And fatigue, as you would know, nurses know this because we talk to patients, as their fatigue increased, their quality of life went down. So that's really an important thing that we could focus on and improve their quality of life. and comorbidity was not predictive of quality of life. AML in older adults associated with poor outcome. On the left, you see the percent of new cases broken down by age groups. The new cases occur in the 65 to 84 age range. As we were saying, it's a disease of older patients. But what's really sad, if you look on this side, this is looking at survival. So if everybody survives, you know, the line goes straight across. That would be 100% survival over 10 years. But what we see is this 65 to 74 is right here, and greater than 75 or 75 and greater is here. So this is the group that has the worst survival. So I'm sure you're aware of that. And then we want to talk to our patients about poor outcomes we see with secondary and treatment-related AML. De novo is the dark blue bar here. This is cases per 100,000 person years. So that's the most frequent type. And then secondary AML is the gold bar here. So that's the next most common. And then the burgundy is therapy or treatment-related AML. On this side, again, you see survival probability. What's really sad to me is this treatment-related AML has really like a dismal prognosis. You know, they don't make it very long at all here. And these are our patients that were treated for another malignancy and then developed AML as a result of that. These are the novel therapy categories we're discussing tonight. Novel cytotoxics, CPX-351, Vosaroxin, FLT3 inhibitors, you can see those, and Acidenib, which is an IDH inhibitor, Venetoclax, a BCL2 inhibitor, and we have our antibodies. Cytarabine and Daunorubicin is a liposome. It's CPX-351 or 351. It's 100 nanomolar bilaminar, that's hard to say, liposomes. It's a 5-to-1 molar ratio of cytarabine to Daunorubicin. 1 unit of cytarabine is 1 milligram, plus Daunorubicin, which is 0.44 milligrams. It was tested in a phase 3 study in fit older patients with high-risk secondary AML. Remember back to our survival curves. So this is a really important drug for those people that are not living very long. And you can see the key eligibility criteria. They had to be previously untreated. My quality of life study included several patients that were on CPX-351 because it was an inpatient regimen. So it improves response, survival, and other outcomes. So you can see the CR, the percentage here for CPX, 37.3, 7 plus 3, 25.6. And then your CRI, when you had CRI plus CR, you can see those. Their survival and 30 and 60-day mortality were lower than 7 plus 3. Then we have Vosaroxin, an anti-cancer quinolone. It's also a topoisomerase 2 inhibitor. It was tested in phase 3 VALOR study as part of a combination with cytarabine versus cytarabine alone in relapsed refractory AML, which is also a difficult to treat age group, or AML in general, relapsed refractory. And it did include over 400 patients who were 60 years of age and older. When they did the initial results, looking at overall survival improvement, in the overall population, they didn't see improved outcomes looking at survival and response. But in the subgroup analysis, when we looked at older patients, you can see that the addition of Vosaroxin improves the survival in older patients with relapsed refractory AML. You have a complete remission, 31.9 versus 13.8. And median overall survival 7.1 versus 5 months. And there was no difference in the 30 or 60-day mortality in the patients 60 years of age or older, but they did have higher rates of stomatitis. Nurses are good at helping patients with stomatitis and subsequent infections. Again, those are right down our alley. Midostaurin is next. This is a FLT3 inhibitor. You remember we were talking about FLT3 ITD. Midostaurin is an oral multi-targeted kinase inhibitor that was just FDA approved within the last week, a little over a week. So hooray, we have the first new FDA approved therapy in over 40 years. That's something to get excited about. Yes, I think so too. I agree. So when added to chemotherapy induction and consolidations in patients with FLT3 mutant AML, midostaurin treatment led to a 23% improvement in overall survival. That's wonderful. Another FLT3 inhibitor that's in development is gilteritinib. This is a novel, highly selective, potent oral FLT3 and AXL inhibitor. You can see that it's active against FLT3 ITD activating and FLT3 D835 resistant mutations. In the phase 1 and 2 trials that were completed, it was well tolerated with prolonged responses, and it's currently in phase 3 testing for relapsed refractory FLT3 mutant AML and is being used as maintenance post-hematopoietic stem cell transplant. There are multiple IDH inhibitors in development for AML. This is a list of some of them. And the closest to FDA, it's at priority review at the FDA for relapsed refractory AML, would be the IDH2 inhibitor enasidenib. And then Venetoclax, it works by binding to and inhibiting overexpressed BCL2. You may be familiar with this, many of you, because we use it for CLL, but it's now being tested in AML in 2 phase 3 studies, and you can see those there. So in summary, our modern understanding of the molecular features of AML has really opened the door to the development of these newer therapies with potential applications in many different treatment settings. We have the novel cytotoxic agents. Natasha is going to go deeper into the explanation of those. She's going to review CPX-351 and Vosaroxin, which appear to be effective in our older high-risk patients and the relapsed refractory patients, respectively. And then we're going to look at targeted therapies such as FLT3 and IDH mutations as well as BCL2. Eileen Galinsky is going to cover that with you. And this does show great promise in AML. And I know that hematology and oncology nurse professionals, you are the front lines of care. You're there for the patients. You help explain their disease. You can go over these prognostic features with them. And I'm really very thankful for nurses. Without nurses, our teams would just fall apart. The patients really look to you for helping guide them, helping them interpret the complex terms that we see, and really providing emotional support. For patients like Emily, we become her family. So I thank you for that. Next, we're going to take an in-depth look at novel therapies in AML, and this is going to be presented by Natasha Johnson.
Okay, good evening to everybody. I feel very privileged to be here and to discuss new novel cytotoxic therapies that look promising and that we may soon have for our AML patients. So first, cytarabine-based induction and consolidation therapy is our standard of care for AML, and that's what we've been using a very long time. This is very intense chemotherapy, and it can be difficult to tolerate. And so we need to ask ourselves, are all of our patients being treated? The answer is no. According to the surveillance, epidemiology, and end results data, the majority of patients who are being treated with AML are younger, they're male, and they're married, and they're less likely to have secondary AML, comorbidities, or poor performance statuses. As Sarah had mentioned, the incidence of AML peaks between 65 and 84. It's these patients that many times carry worse prognostic factors, and their outcomes are usually poorer. According to SEER and Medicare data, also show us that it's less likely that these patients are being treated, and without being treated, their overall survival is very dismal. So in summary, we definitely have unmet needs here for our older patients with AML and high-risk disease. So we ask ourselves as nurses, can we accomplish certain goals with these new therapies that may be becoming available? Can we improve survival and get patients to transplant if that's their choice and something that they would go do would be an option for them? Can we decrease treatment-related mortality? Can we improve their quality of life? Can we decrease hospitalizations? Can we decrease toxicities? And most of all, can we now treat a greater proportion of these patients who are older with high-risk disease? hopefully we can begin to answer yes to many of these. Recently, there's been multiple studies done on newer cytotoxic therapies testing in AML. Unfortunately, clofarabine was inferior to our standard 7+3. But tonight we're going to go into a little more detail on two agents, CPX-351 and onvosiroxin, that are showing promising results. Here we have our 70-year-old patient, Mark. He presents with a diagnosis of secondary AML. He went through MDS previously. He has a good performance status. And now he tells us that he wants to be aggressive with therapy. And he's asking if transplant can be an option, although he questions it because of his age. First, what we need to do is review with him the bone marrow biopsy results and aspirate. We need to talk about his cytogenetics and the molecular studies, because this is going to decide where our treatment is going to go. We need to explain to him possibilities of treatment, whether that is induction inside the hospital or clinical trial. Induction is a very long hospital stay, and when I see patients before I admit them for induction chemotherapy, I go into detail about how long that stay is going to be, what's it going to be like, and what follow-up is going to be like. And I really see that if we tell them these things, they end up doing much better. Regarding transplant, we're going to discuss later how this may be an option and CPX may be a bridge to go forward. So we can explain to him that transplant may be an option, and if he can obtain a complete response, he has good performance status, a suitable donor, then transplant may be an option for him to go to. So I think also that it's important, if we're going to discuss transplant, that we should explain some of that. Patients have many, many questions about transplant, and going over with him what that hospital stay would be like, that they need to remain close to the hospital, usually for the first 100 days. It's very frequent follow-ups, and they need a caregiver to take care of them. So let's go in and talk about CPX-351. What exactly is it? It combines two anti-neoplastic agents, Cytarabine and Daunorubicin, which we have been using for some time, and they are combined within a liposome at a 5-to-1 molar ratio. In preclinical studies, at this ratio and concentration, they were shown to be most synergistic. Researchers believe that it accumulates within the marrow and that there's preferential uptake of the liposomes by leukemic cells, leading to increased cell death. Previously, we had phase 2 studies that showed very promising results that have led on to phase 3 studies, and currently it's in a phase 4 expanded access protocol. One thing to note is that during the phase 2 and 3 studies that we're going to talk about, patients received CPX-351 at 100 units per meter squared. That equals Cytarabine 100 milligrams per meter squared and Daunorubicin at 44 milligrams per meter squared. Now we know that Daunorubicin is an anthracycline, and so we need to make sure that we are looking at the lifetime cumulative dose here and what they receive. And this is very important in our treatment-related AML patients, because many of them may have received anthracycline in the past. We're going to go over the phase 2 study of CPX-351. This is a study that enrolled 126 newly diagnosed patients with AML who were between the ages of 60 and 75 who were fit for induction chemotherapy. The primary endpoint was composite complete response. So that included a true complete response and a complete response with an incomplete count recovery. So that means at the time of the bone marrow biopsy, the platelets had not recovered to at least 100,000, or ANC had not recovered to at least 1,000. Overall, the composite complete response was higher in the CPX arm. However, true complete response, there was no difference between arms. Then they performed a subgroup analysis, and that's what we see here on 52 patients with secondary AML. So the patients in the CPX arm, you can see that they had improved response, improved event-free survival, improved overall survival, and decreased 60-day mortality. So the results of this study led researchers to a phase 3 trial. The phase 3 trial was a randomized, multi-center, open-label trial. It included 309 patients with high-risk AML, comparing CPX 351 to our standard 7+3. High-risk patients means patients who had treatment-related AML, patients who had AML with previous diagnosis of MDS or CMML, and they may have or may not have received hypomethylating agents. This also included patients with de novo AML, but they had an MDS karyotype. Primary and secondary endpoints were reached, and here we can see that CPX was more active than 7+3 in older patients with AML. CPX improved overall survival as well compared to 7+3. The median overall survival for patients in the CPX arm was 9.56 months compared to patients who received 7+3 at only 5.95 months. At 24 months follow-up, 31% of patients who received CPX were still living, compared to only 12% of patients who received 7+3. That's a big difference, and for me, very exciting as I see these patients in clinic and grow close to them every single day to see them still alive 2 years out. So what about survival by age? It was broken down even further to 2 age groups, 60 to 69 and 70 to 75. Researchers saw that there was a 32% reduction in the risk of death in the 60 to 69 age group. There was a 45% reduction in the risk of death in the 70 to 75 age group. So this indicates it was really beneficial to the older patients. If you go back and you remember one of our first slides, we asked, can these newer agents get us to transplant, and could they be a bridge? Well, here we see that CPX may be a successful bridge to transplant. This bar graph shows that there was an increased percentage of patients who had received CPX 351 for induction that were able to go on to transplant compared to those patients who received 7+3. So in remembering our patient Mark, who was 70 and questioning if he could even go, here we can show that if this drug becomes approved and with agents like this, he can go on to transplant as long as he achieves a complete response and he's fit and otherwise healthy with a donor. This could be an option. So I really like the information in this slide. Among patients who went on to transplant and those who had received CPX 351 as induction chemo are showing to have better overall survival after transplant. The median overall survival for our patients that had received CPX 351 has not even been reached yet, compared to the patients who received 7+3 at 10.25 months. The reason for this is not exactly clear, but the researchers think that maybe they obtained a deeper response or that they were healthier at the time of transplant. And so, like I said, I am just so pleased with this information because I see a lot of patients before they go on to transplant who are older, and many times when I see them, I'm not sure if it would be the last time. And so that is upsetting and makes me sad. And so this is just so encouraging to me that they can go on to transplant and do well. So let's assume that our 70-year-old patient at diagnosis also has COPD, and he received CPX 351, but he experiences a delayed count recovery. So as nurses, how can we manage him? We need to first explain the threshold for blood and platelet transfusions. Each institution usually has their own protocol, and at Moffitt, we usually transfuse for platelets less than 10,000 or hemoglobin of less than 7. But I have to say that in clinic, we really transfuse our patients based off of symptoms and not just a number. I explain to patients that I do expect them to feel fatigue, I expect them to have dyspnea on exertion, but if they're experiencing shortness of breath at rest or severe fatigue, chest pain, palpitations, lightheadedness, dizziness, they may need a transfusion even when their hemoglobin is at a higher level. And this can improve their overall quality of life. We also need to remember when they have comorbidities like pulmonary or cardiac diseases, we may need to keep their hemoglobin a little higher. We watch their iron carefully and we do treat it if it's needed. Regarding platelet transfusions, It's important that we teach our patients exactly what petechiae are. We use that term a lot, but my patients many times have no idea what that means. We can explain to them that they may get oral blood blisters in their mouth or have spontaneous bleeding, and we need to transfuse them if they start to experience those symptoms, even if their platelets are a little bit higher. Here we go over the safety summary of CPX 351 compared to 7+3. So overall, the adverse events were generally the same. Differences were seen with increased infection and bleeding due to delayed account recovery related to myelosuppression. It is important to make a note, however, that although there was increased myelosuppression, the 30 and 60-day mortality rate was lower in the CPX 351 arm, so that did not lead to an increased death rate. This shows you exactly how long it took for counts to recover after receiving these therapies. For patients who received CPX 351, it took an average of an extra 6 days for their neutrophils to recover. And for platelets, it took an extra 7 days for their platelets to recover greater than 50,000. What do we need to do here? This is where we're going to discuss managing our patients with delayed count recovery. It's very important following induction. We are seeing our patients in clinic at least 2 times a week to assess for transfusion needs. If they're severely thrombocytopenic, we even see them 3 times a week. And if you have an infusion center that's available on the weekend, you can set them up to be seen there. We need to review CBC and differential with our patients. I go over the white blood cell count, hemoglobin, and platelets and explain exactly what the biological function of those are, what's normal, abnormal, and what we're looking for here. We need to go over neutrophils. Many times patients don't understand that when we say ANC and neutrophil count, we're talking about the same exact thing, so explaining that. We can discuss neutropenic precautions, and when their ANC is less than 1,000, go over that they need to call us if they experience a fever, and the serious complications that can occur if they do not contact their provider. That's very important. Explain that they need to avoid fever-reducing medication, because I will have patients come see me and tell me they had a fever 2 days ago and they took Tylenol and they didn't call, and then they hear a speech. So make sure that you tell your patients, to call you if they have a fever, no matter what, even if it's night or weekends. So again, we're going to go over the hemoglobin, platelets, and what the threshold is for red blood cell transfusion, platelet transfusions, and follow their symptoms. Don't just follow their numbers. Another thing to note and point out is I see that patients will take ibuprofen and Motrin, Aleve, Advil. They'll take NSAIDs when their platelets are very low, and they don't understand what NSAIDs are. So if you can remember to just explain those to your patients and tell them what all those medications are underneath that category, and that they need to be avoided when their platelet count is low, less than 50,000. Our patients are also on anticoagulation medication, and that needs to be held as well. Sometimes we even need to collaborate with the cardiologist. CPX 351 is currently available in a phase 4 expanded access protocol. It is for patients with secondary AML who are suitable for treatment with intensive chemotherapy. They can receive 2 inductions and up to 4 consolidations, and they'll be monitored for side effects. And study enrollment is available through the commercialization of CPX 351. This is very exciting as well. There's a phase 2 study going on right now that is currently enrolling patients with newly diagnosed AML who are at high risk for induction mortality, and they're studying CPX 351, but at a lower dose of 50 units per meter squared or 75 units per meter squared, and the interim results are very promising. So as now we've discussed, currently in the phase 4 study, patients have to be fit, but a lot of times we have 70-year-old patients that aren't as healthy, or they have comorbidities and they cannot receive induction chemo. So hopefully we will also see some more options available for us. Our next patient is Terry. She's 62 years old, and on initial presentation, she had de novo AML with a good performance status, normal karyotype, and no FLT3 mutation. She achieved a CR after receiving cytarabine-based induction and consolidation therapy, but unfortunately, after 5 months, she relapsed. Her performance status has now deteriorated, and she asked about options other than transplant. This is a group of patients where we have very few options for treatment, and their outlook and overall prognosis is very, very poor. We can discuss, though, with her that hopefully we will see a new medication, Vosaroxin, that may be an option to patients in this setting. We need to discuss the goals of care, especially with patients in clinical trial. They have to come to the clinic more often. Sometimes they need transportation and somebody caring for them. So go over those things with your patients when they're thinking about what treatment they want so they know what is expected. What is Vosaroxin? It is a first in its class anti-cancer quinolone derivative. It is also a topoisomerase II inhibitor. It intercalates DNA. It inhibits topo2, causing double-strand DNA breaks that leads to G2 phase arrest and apoptosis. In contrast to other topoisomerase II inhibitors like the anthracyclines, because it has a stable quinolone core, it has less risk for cardiotoxicity, and this is very important in our relapsing patients who may have received anthracycline-based regimens previously. There's also a decrease in tumor resistance because it acts by inducing a p53-independent apoptosis. Because of encouraging phase 2 results, researchers were led to perform a phase 3 study in relapse refractory AML. The phase 3 study was a double-blind, placebo-controlled study at 101 international sites that included 771 patients. This was a very large study for this population. They were randomized to either Vosaroxin plus Cytarabine or placebo plus Cytarabine. In preclinical studies, the combination of Vosaroxin and Cytarabine showed synergistic anti-proliferative activity when combined together. The VALOR study here, although unfortunately did not meet its primary endpoint, when they had done a pre-planned subgroup analysis, it showed that it had an advantage in patients that were older than 60 years of age with relapse refractory AML, and over 2/3 of the patients in the study were over 60 years old. So here we can see that there was a superior response compared to the control arm. Now we can see here that there was also a durable survival advantage. More patients survived over time when they received the combination of Vosaroxin plus Cytarabine. A further analysis was done amongst the group of relapse refractory patients. So those patients that showed even more benefit were ones who had relapsed early. So that was relapsing after 90 days of achieving a complete response or before 12 months, or those with refractory disease, which was defined as persistent disease, or only having a complete response for less than 90 days. This is a safety summary for Vosaroxin. We saw these complications more in the Vosaroxin arm compared to the other arm. There was an increase in febrile neutropenia, stomatitis, hypokalemia, bacteremia, sepsis, and pneumonia. It is important to point out, though, that many of them were related to myelosuppression, although it did not result in increased mortality in these patients. Early mortality was equal between both arms of the study. What is the nurse's approach to Vosaroxin and taking care of patients on this? We need to educate patients for potential adverse events that can occur, and especially our older patients who may be at higher risk for more severe complications due to comorbidities. We can watch for stomatitis, bacteremia, and sepsis. Educate your patients on neutropenic precautions and emphasize the seriousness of bacteremia and sepsis. Regarding stomatitis, ONS has excellent resources in putting evidence into practice that you can use to help manage this in your patients. And I'm sure you manage it with many other chemo drugs, so you're probably very well at doing that. In summary, cytotoxic therapy remains vitally important in our AML patients, and new options, particularly for the elderly, are available. CPX 351 may represent a new standard of care for older patients with high-risk AML. Be prepared to educate these patients and their families on what to expect, and also if they decide to go to transplant. Monitor for and manage them as they may experience a delayed count recovery. With Vosaroxin, this is showing a durable response in our patients with relapsed or refractory AML who are over 60 years of age. Be prepared to address toxicities that may trouble older patients, including sepsis, bacteremia, and neutropenia. And that's it for me, so thank you very much for allowing me to come.
Well, thank you all for having me here, and thank you, Sarah and Natasha, for awesome presentations. I hope I can do as well. So my discussion is going to be on targeted agents in AML and a nursing perspective. So just want to reiterate, I know most of you know this, but AML basic facts. What is AML? It's an unbridled proliferation of hematopoietic stem cells of the myeloid lineage. It results in bone marrow failure, and unless treated, successfully treated, patients will die. And as we all know from conversations we've had earlier, and you're going to, even with treatment, they can die, but clearly, as Sarah's slides show, you don't treat it, it's an inevitable fact. Risk factors are age, as we know. It's a disease of the elderly. Prior chemo exposure for other cancers increase your risk. Ionizing radiation and industrial solvents. There's 20,000 new cases of AML each year in the US, and as you can see, over half of them end up dying of their disease. So again, just to put in perspective what has been said tonight, we have risk factors to help guide us in our treatment decisions and also plan our discussions up front of what is the best approach to treat our patients. Again, age, number one, been there for years. Cytogenetic abnormalities, and looking at RNA mutations, as well as multi-parameter flow. And as Sarah mentioned, flow is important at the beginning to know what antigens the blast cells are positive for. And as I'm going to talk about, that will help guide us with antibody therapy, but also similar in ALL, where MRD has been the top bar for monitoring responses and success of cure. It is becoming a very hot topic of MRD in AML. Molecular studies are, over the last couple of years, have come into fruition because as AML, as you know, is a heterogeneous disease. And you may say, well, you have these risk factors. We have the lovely 7 and 3 we've been using for 30 years. Why do some people do well, some people don't? Why do people relapse? And therefore, what we're finding is there's more to it than the first two categories listed as prognostic factors. There's another source driving the leukemia to make it respond to therapy or make it a highly proliferating disease that we need better treatments for. And again, I'm going to talk about FLT3 mutations. There's two. The ITD and the point mutation. FLT3 mutation is the most common mutation in AML in about 30% of cases. IDH1 and 2 is the second most common, about 18 to 22% of AML patients. And I'm going to briefly talk about throughout my presentation add to what Sarah talked about of what is favorable and what is unfavorable. So here's the laundry list. About 15 years ago, there'd be nothing on this slide, and now we have multiple agents, and they're all coming at the disease from a different aspect. So when I originally did these slides, I said pending FDA approval, and I had to call up, and right away last Friday, we were able to say it is now approved, and I'm going to talk about midostaurin. Also, probably by the end of 2017, we're going to have CPX 351 available for those older patients with secondary AML, and enasidenib IDH2 inhibitor for relapsed refractory patients. Also, new chemo agents that maybe 2017, but I don't want to push my luck for so many drugs, will be Versaroxine. Also, gemtuzumab was approved years ago in relapsed AML and was pulled from the market. It is now coming back to life. Also, SGN33A is a similar antibody for CD33. And Venetoclax is approved, obviously, for CLLL, and we'll talk about why that's going to be helpful in leukemia. And the others I'm not going to address, but there's a huge list in clinical trials. So what makes FLT3 mutations a problem? So it's the most common in AML, about 30%. It's going to guide us in relapse decision-making. They have an increased rate of relapse. Also, when we talk about the RATIFY trial that got midostaurin approved, it took so long to get that study done, which I'll talk about. About 3 years into it, in Germany, they found that people in CR1 with FLT3 mutant disease do better with transplant, and that trial was not set up for a post-transplant FLT3 inhibitor. IDH mutations, they work on DNA methylation and cellular differentiation. Not going to really talk about the KIT mutations. And BCL2 binds and sequesters pro-apoptotic molecules and inhibits BCL2, which primes cancer cell death. So I have a patient, John, who in a usual Friday afternoon in my practice, I get a call that he is in the ER with elevated white count of 100,000, hematocrit 28% with a platelet count of 56,000, and he has 65% circulating blast. In my head, I'm already thinking he has a very good chance of being FLT3 positive. FLT3 positive patients are more common in those with a highly proliferating disease, which is evident by the elevated white blood cell count. He is an educated gentleman, so he is aware that there may be other things to add to his therapy. But the most important thing I'm going to do is tell him that I need to confirm his diagnosis of AML. I need to do an aspirate biopsy for molecular, chromosome, and mutational analysis. How do you treat this person? Well, if this was 6 years ago or later, you would say you're going to get 7 and 3, hope for the best, and try and transplant you. We have, there's clinical trials out there now looking at FLT3 inhibitors in the upfront setting. So I'm going to think about a clinical trial for him. Obviously, I don't have it available in my hospital yet to give midostaurin, but he would be a classic candidate for that. Just want to briefly show again, and Sarah touched on this as well, the relationship between chromosomes and FLT3 mutations. And as you can see, the worst case scenario for a patient with newly diagnosed AML is to have abnormal chromosomes and to be ITD positive. Best scenario, as you can see on the bottom, is to have good risk chromosomes and be ITD negative. So there are numerous drugs now that work on FLT3 inhibition. As I said, midostaurin was the first. There's quizartinib, also referred to as AC220, crenolinib, and gilteritinib, ASP2215. My take-home message on this is they're all in different clinical trials. I want you to focus on the half-life of these. As you can see, crenolinib has a very short half-life. It's a 3 times a day drug. and that will be important when you pick your patients for clinical trials. Quizartinib, gilteritinib are long-acting and they're once daily. Also of note, crenolanib and gilteritinib work on both ITD positivity and D835 mutant patients. So the RATIFY trial was a phase 3 trial that started, I want to say, 2005. To get 717 patients, we had to open this trial because it was started in the cooperative group at CLGB all over the world. Because, as I mentioned earlier, 30% of patients have the FLT3 mutation. To go on this trial, you needed to have your molecular analysis back within 48 hours. It had to be centrally reviewed. You got randomized up front to, everyone got the same chemotherapy. You either got randomized to midostaurin or placebo. Everyone got the same induction regimen, 4 rounds of consolidation, and you had a year of maintenance. Now, I mentioned earlier, there was nothing in this setup for transplant. So if you did go to transplant, that was considered an event, and you were removed from trial. So it was exciting when this was first reported to show that people that got midostaurin did much better. And you may say the numbers don't really show that, but you have to keep in mind this assessment was made at 60 days after day 1 of chemo. Now, we know that you do a marrow on day 15, and some people, about 30%, need another round of chemo. So a lot of trials make their assessment when you recovered from that second round of chemo. Here, it was 60 days from day 1. So that's important to keep in mind that with that, 59% of people went into CR. Also, on the second half of this slide, as I mentioned, some people got taken off for transplant. And when they looked at the sub-analysis, that even patients that survived their transplant, because one of the other objectives was overall survival, if they got any bit of midostaurin before they went to transplant, they had a better outcome. So I'm going to switch gears now. So what do you do? Obviously, unfortunately, people still relapse, even with FLT3 inhibitors. And here is a patient who got transplanted and is doing well, comes to clinic about 150 days from his transplant in first remission. He is off his immunosuppressive therapy. He has no signs of GVH or GVL. He has dropping blood counts, and he has peripheral blasts. So I need to talk to him that I suspect, obviously, that he has peripheral blasts, that he has relapsed. My focus needs to be, and our focus as nurses need to be, what does this actually mean? It doesn't mean a death sentence anymore, thank God, but we have to stress the importance that we need to do everything, he's young, to get him in a second remission. Also educate him that I'm going to repeat his bone marrow and all the same tests I did at his original diagnosis. Not everybody will relapse with the same mutational profile as they had when they were first diagnosed. So the FLT3 may or may not be there. He could have additional mutational abnormalities. So it's very, very important to never just assume and always repeat everything like it's the very first time. So I want to talk to him about my goals of trying to get him into a second remission and how best I'm going to do that. I'm going to talk to him about clinical trials. He turned out to have relapse with his FLT3 mutation. So I'm going to talk about clinical trials using FLT3 inhibitors in the relapse setting. Gilteritinib and quizartinib are the 2 relapse trials. You could also consider non-FDA approved usage of sorafenib, which is approved for renal cancer. There is anecdotal studies that it does work. It's a FLT3 inhibitor. We've all used it in combination with hypomethylating agent or even as a single agent. And also now, I only can assume with midostaurin, FDA approved, albeit for a different indication, people will be using midostaurin in the relapse setting. So gilteritinib, there's a trial going on that looked at dealer's choice chemo. So when people relapse and they're young, you're going to try and salvage them. Up until a couple years ago that we have targeted therapies, you would salvage them with intensified chemotherapy. These trials are now looking at which is better. Do they respond to chemo, or should you focus on what their mutation is? And if you believe the ITD was what caused their relapse, it makes sense that you would want to target that. Quizartinib, same trial, except this one looked at you had to have relapsed within 6 months of achieving a remission. So I just want to briefly talk about the results of these trials, and I'm not going to bore you with the percentages of response, but I just want to show you on this chart, as you can see, overall response rate, it was 53% in those that were ITD positive and 36% in those that were ITD negative. And this was a single agent, and it's important to know that they held this as a single agent for, as you can see, about 10 weeks, not great, but it possibly can get them to a transplant. Gilteritinib, next generation FLT3 inhibitor, also known as ASP22115. It is a selective inhibitor of FLT3 and AXL with activity against both ITD and TKD. It has moved from the phase 1-2, completed. They've identified a phase 3 dose. Similar, and I'm going to summarize this in a few slides, these targeted therapies, TKIs, have pretty much the same toxicity profile. GI toxicity, potential for hepatic increase in lab tests. Most are generally below grade 3 in toxicity. The gilteritinib trial, again, just to break it down, overall response rate 55%. As high as, if you combine those with the D835Y, 62%. And then those with the point mutation also had a 17% overall response rate. And as this trial, you were allowed to have received a prior FLT3 inhibitor. Just to show you, even if your leukemic cells were previously exposed to a FLT3 inhibitor, you could still respond to this with an overall response rate of 42% that was seen. If you never saw a tyrosine kinase inhibitor, you had up to a 56% chance overall response rate. Gilteritinib is moving on to a phase 3 trial, and this is a randomized trial looking at single agent gilteritinib versus dealer's choice of a chemo-based regimen for salvage. So if you use MEC, FLAG, IDA, or low-dose Ara-C, or if you didn't think someone could handle chemo, you would give them azacitidine. There also is a new study started that we're participating in at our site, and maybe you guys are as well, using gilteritinib in the upfront setting, similar to the RATIFY trial. Crenolanib, just briefly, 27% CR/CRR rate in patients with FLT3 mutations. There's a phase 3 trial in the relapse refractory setting, and there's an upfront newly diagnosed, again, similar to the RATIFY trial in setup, except if you go to transplant, you're allowed to come back and get on crenolanib within 100 days of your transplant. That trial just met accrual about 2 weeks ago. So as a nurse, when you see these patients, oral therapies are great. One of the pet peeves of mine and frustration as a nurse with oral agents is obviously patient compliance. How do you get your patients to take their meds every day? Problem with the crenolinib is it's 3 times a day. When someone is status post-transplant or their year of maintenance, when they're feeling well and in remission, who wants to take pills 3 times a day? My patients do it, but they miss a lot of doses. One thing I have found, and I think it's important, is if you communicate with your patient the importance of taking their meds every day, also an open dialogue, have them describe their symptoms, because maybe they're not taking it because they feel nauseated, and maybe we're not treating their nausea to the best of our ability. So I think it's just important to always educate and open dialogue. Also, be mindful of these drugs. Avoid azole use, drugs that cause QTc prolongation, and the favorite for all of us that we face nearly with every drug is CYP interactions. Okay? And again, with oral drugs, they're wonderful, but it relies a lot on us as staff members to educate our patients on compliance. The most common side effects in summary of FLT3 inhibitors are nausea, vomiting. Small population had some mild skin rashes. They're all controllable, but it's just things to warn your patients about. IDH, so the second mutation of commonality in AML is IDH mutations. IDH, the key on this slide, I just want you to know there's 2, IDH1 and IDH2. IDH2 is more common than IDH1. IDH1 works on the cytoplasm of the cell, IDH2 on the mitochondria, and it's an acquired mutation in the early development of AML. And axitinib, AG221, is the farthest along IDH2 inhibitor. AG120, ivositinib, is the IDH1, which is following along. These are selective reversible inhibitors of the mutation. AG881 is a pan compound that Agios Pharmaceuticals has put on the back burner right now. IDH301 is another IDH inhibitor, and FT2102. So there is numerous drugs out there targeting this mutation. So I'm going to have another patient. Marilyn is a lovely 62-year-old woman who has relapsed AML. She's healthy. She relapsed with IDH2. She comes to our site to see if she can get on our clinical trial. She is eligible for the clinical trial. What can I say to her to educate her? So we talked about the basics of oral medication and compliance, but there's a handful of major side effects that are controllable. We just have to be aware of and educate our patients on. Just like with any relapsed patient, you're going to monitor their CBC because their white count, hematocrit, and platelets are going to be abnormal. With these inhibitors, they're slow acting. Their counts could get worse before they get better. We saw with both IDH1 and IDH2 differentiation syndrome, very similar to what is seen in APL. You get an elevated white count, weight gain, fever, shortness of breath. It usually happens within the first 1 to 2 months, so it's something when they're coming in to see you to be aware of. You can use Hydrea during the first month. Again, this is on clinical trial. Educate your patients on myelosuppression. These drugs do cause your counts to go down before they get corrected. It takes more than 1 cycle to see a response, so you need to be patient. And again, just like with any TKI, avoid azoles, monitor over-the-counter medicines, and anything that could potentially prolong QTc. The take-home messages are controllable side effects, all basically the same, GI toxicities, and potential for liver abnormalities. The important thing to know is as a single agent in the relapse setting, we're seeing CR rates of 18%. And we're also seeing 16% in the IDH1, which is good. You got to keep in mind that these drugs are not the end-all, be-all, And if you have a young patient that relapses that's on one of these trials, similarly to what was discussed in the last talk, is you could use this as a bridge to transplant. As you can see, people tend to lose their response 6 months or a year after. I just want to go over a summary of the phase 1-2 study design of enasidenib. And again, you can see it had many arms. People were eligible, relapse refractory greater than 60, relapse refractory less than 60, untreated patients over the age of 60 that you did not think could handle standard chemotherapy, or any other hematologic malignancy that did not fit in the above arms. The standard dose based on those trials led to the phase 2 of 100 milligrams orally once a day. And here, side by side of the breakdown of responses, those with untreated AML and those with relapse refractory AML. And the overall responses was 37% and 42%, which is pretty good. I have a lady who did not want a stem cell transplant and did not want to go through induction chemo through her own choice at age 70. She's been on the IDH2 for 2 years now, and she is still in remission. Safety summary, again, it's early, but it's very, very well tolerated. Most common AEs are nausea, pyrexia, diarrhea, and fatigue, and those usually happen early on, and as you get used to the drug, patients don't seem to have as much side effects. Those that were shown to respond in the relapse refractory setting improved their ANC by the first cycle. These have been durable, but they tend, again, after like 7 months to a year on the average, they all start showing their IDH mutations reoccurring, and obviously that means they're going to eventually relapse. The phase 3 identify trial of enasidenib versus any chemo-based regimen in older patients with IDH mutant late-stage AML is ongoing in trials right now, and you get randomized to IDH or azacitidine plus best supportive care, LODAC, which we don't use anymore, but they use it quite a bit in Europe. And that's ongoing right now, and they're looking at overall survival and if you can get to stem cell transplant. In summary of IDH inhibition, very well tolerated, few grade 3 non-heme toxicities. We've had to reconsent everyone. There's been some reported cases of patients developing neuropathy. So that's, as people stay on these drugs longer, we're constantly now seeing different side effect profiles than we originally thought. We do not know the mechanism of neuropathy. Again, differentiation syndrome seen during the first 2 cycles. Educate your patients to be patient, take 3 to 4 cycles to respond, monitor your azole, CYP drugs, and educate about myelosuppression. Just quickly, I want to talk about 2 exciting other means of trying to treat this bad disease. BCL2 is an anti-apoptotic protein. Unlike in CLL, it's frequently but not universally overexpressed in AML blasts, but it does appear to be expressed in leukemia stem cells. Venetoclax is a specific inhibitor that acts on BCL2, and it started as a single agent in multiple relapse refractory patients, and they had a remarkable 20% response rate. That led to using it in combination with hypomethylating agent in the United States, and in Europe, they're doing low-dose cytarabine in older patients. And as you can see, this was reported. They have a response rate of 54%, which is very exciting. And even broken down, people with secondary AML and poor risk also responded to this combination. There's a trial that's still ongoing. They are expanding enrollment after shutting it down as they met accrual, is Venetoclax with HMA and newly diagnosed over the age of 65. Based on your center, you're giving it with decitabine or azacitidine. The median age on this trial is 73 years old. 41% of those people had adverse risk cytogenetics. It's highly active with an overall response rate of 76%, which is incredible. Combination therapies are being looked at as well. And I have a patient who started with, she was 80 years old, newly diagnosed AML. I put her on this trial. She went into remission. She is now 82 and a half, and she's on her first trip visiting her family in Mississippi. So we're doing good work, and that is why we do it. Major side effects profile with Venetoclax is myelosuppression. Expect dose reductions. You're allowed to use growth factors to keep it going and keep the therapy. Getting some Venetoclax into them appears to be highly beneficial. Again, educate about myelosuppression. Now, you may say CLL has a lot of tumor lysis. We did not see this at all in AML, but still, you gotta be mindful, you never know, to look out for tumor lysis, put people on antihyperemics, IV fluid, et cetera. Be mindful of myelosuppression, educate them. You are allowed to use growth factors, including romoplastin, to help their platelets. Lastly, CD33 antibodies, as I mentioned. CD33 is expressed 90% of patients on their AML blasts. Remember I said at the beginning, flow cytometry tells you what antigens you could potentially attack. Gemtuzumab ozogamicin was previously approved. It's a CD33-directed antibody. They're looking at re-establishing that. Venetoclax taurine SGN33A is in clinical trials. The major point I want to tell you about CD33 antibodies is the risk for veno-occlusive disease. That was one of the reasons why gemtuzumab was taken off the market. People got into remission. Now you think about, you're giving someone non-chemo to get them into remission, you know you probably have to follow that up with a stem cell transplant. And what they found was if you gave gemtuzumab, and they saw it on clinical trials as well with SGN, too soon, too close to your stem cell transplant, you had a higher increase of VOD. If you relapse after transplant and you receive this agent, you also had an increased chance of getting VOD as a result. So that's my major take home on that. Lastly, and this is very new, CD123 is another marker that we've identified in AML. It's an IL-3 receptor. It is marked on the leukemia stem cell, and it distinguishes itself from the regular hematopoietic stem cell. And it is overrepresented in the leukemia blasts, and there's clinical trials using agents that target this, antibody-drug combination and also bispecific antibody therapies. So in conclusion, please keep in mind mutations do matter. We know more and more favorable chromosomes, again, are very important. They help guide you in knowing someone's prognostic value. Favorable chromosomes, CBF cytogenetics, normal chromosomes with NPM1 and FLT3 wild type, those are good chromosomes to have. When you're treating AML in the 18 to 60 range, it is even more important to understand their molecular makeup of their disease. And also keep in mind, that's the population we're focusing on of stem cell transplant, and that should be our goal of getting someone to a stem cell transplant. FLT3 inhibitors are finally here. I never thought it would happen. Midostaurin is approved, gilteritinib is on the tails, new agents, CPX, the IDH inhibitors, CD33 antibodies, and BCL2 inhibitors. And I just want to say thank you, and I'm sorry for keeping you guys here so long, but thank you for listening.
We'll start answering the questions that have been submitted.
So the question here is regarding CPX 351, and they're asking how is it given, how many days? CPX 351 was given at the dose of 100 units per meter squared. It's given intravenously on days 1, 3, and 5 while patients are in the hospital.
The question is gemtuzumab coming back, and is it new and improved? The answer is yes, it's coming back, but they haven't done anything to change it, except we have more education and more knowledge of the side effects. Probably in retrospect, it got approved too soon without gathering all the information that we need.
I can take this one. There's a question about the new FLT3 oral chemotherapy. Is that first line, or do you have to fail 7+3 first? As we're using it right now, we're giving it in combination with induction chemotherapy, and we're giving it with consolidation. I think we give it for 8 through 21, and it's a twice daily dosing, I believe, on the
50
patients
BID.
that we're using it
50.
on, 50 milligrams BID. But remember, this just got FDA approved, so I haven't seen a package insert yet. I just know from our experience what we're doing. They don't have to fail 7+3, but if they have a FLT3 mutation, then you combine it with your standard induction chemotherapy is the way it's being administered.
Because the indication for approval, since it had to mimic the Ratify trial, it was 18 to 59. So that's how the label's going to be approved for newly diagnosed 18 to 59-year-old patients with FLT3 mutation in combination with induction.
I will say, too, when we have patients that we're giving off-label use of other FLT3 inhibitors that have been approved for other cancers, if they have a FLT3 mutation, we haven't had a lot of problems getting those approved. But now that we have one FDA approved, you just have to show they have the mutation because we know it works.
I will take this. Question, it was questionable use of GCSF with novel agents. Well, GCSF has been shown to stimulate blasts, so trials that allow it is very controversial when you're using it in the relapse setting. If you're using it in the setting where someone's in remission and you want to keep them in remission and keep their therapy on track, that's where, like in the Venetoclax Vidasa trial, they allow it. Because once you're in remission, they want to keep you on track getting your therapy. In my institution, if someone has active disease, I do not use it at all.
The other question on this card is, please explain the difference between de novo AML and FLT3. De novo means they didn't have another hematologic disorder before they had AML. They just have AML. And FLT3 is a mutation that they may or may not have with de novo AML. They could also have FLT3 mutation with therapy or treatment-related AML, and they could have it with secondary AML. And your secondary AML is the AML that you get when you have had a prior myelodysplastic syndrome or a prior myelofibrosis or other bone marrow disorder that then evolved into AML. So I hope that explains it. What print education materials are available for those with low health literacy? A lot of the patient education materials that are on the Leukemia and Lymphoma website are really written at a 6th grade reading level, and hopefully that can be broken down for them. I really try to draw pictures for patients when I'm talking about cells, because sometimes when you even talk about a cell, depending on their background, they don't even understand what a cell is. You know, so you just kind of have to meet them where they are and see how much they're capable of understanding.
So I actually work for the Leukemia and Lymphoma Society, and there's 2 levels of all materials. So
Okay.
there's an easier one, which is called the guide, the AML guide. Of course, everything's detailed, but the guide, and then the regular AML booklet is the one that's a little bit higher level that you might be talking about.
Okay, the AML guide,
So
what
whenever
reading level?
Any of the booklets, it's really more supposedly at like a third grade,
Third grade,
like a fifth
okay.
grade, third to fifth, but the other ones are a little bit harder. So the guide is more simple, and then the regular AML booklet is a little bit higher level.
That's very helpful, thank you.
There are also some other kinds of information, so if they need it broken down, our information specialist can actually discuss it with them if they call by phone, if it's a patient.
I mean, when I first started hearing about mutations, it was hard for me to understand. So really, just thinking about it, looking at drawings of it, YouTubes about mutations, and just really being familiar with them over time is what helps with the understanding. Thank you so much for all of you that are here. And this has been just really a wonderful opportunity, and it's a great time for our patients and for us, the people that take care of AML patients as well. So thank you.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening to this activity. To view the rest of the CE activity, download materials, and complete the post-test for instant credit, please go online to www.peerviewpress.com/QJG. This activity is supported by independent educational grants from AbbVie, Agios, Astellas Scientific and Medical Affairs Incorporated, Celgene Corporation, and Jazz Pharmaceuticals Incorporated.